We'll see a really specialized field today.
Dear audience, ladies and gentlemen, I will try to fly my lecture as speedy as a spacecraft. I will show you a bunch of very interesting cases on my field, and similar to the spacecrafts shoot out to the space to research new horizons, I will try to show you in my field how we are looking for these new horizons. I have nothing to disclose financially. Now, on the off-label side, some of those devices I use today are already FDA approved, but they were not FDA approved at the time when I used them. Some of the devices are FDA approved, but today they are not approved for what I am using them, so I'm using them off-label. I will show you them. This is the timeline of my specialty regarding strokes. This is more important on the right side. Before the 90s, all what we could do for stroke patients were prayers. Now, after that came IV thrombolysis, or particularly intraarterial. The smiley face is there because in 1992 at National Institute of Neurosurgery, I performed my own first streptokinase intraarterial thrombolysis case. And then, well into the 21st century, some new devices were developed, and new techniques were developed by the doctors who use them. So let's go with the basic. The basic is today is large vessel occlusions of the brain. What are the large vessels? Well, my brother is researching artificial intelligence, and when I talk to him, we are talking about, let's say, legal, medical, and scientific aspects of artificial intelligence, and I was warned that don't use artificial intelligence in your lectures. So I asked ChatGPT, what is large vessel occlusion? And ChatGPT gives you the answer which it can find on the internet, and it gives you that large vessel occlusion is a blockage of large proximal arteries, basically the internal carotid artery, the ICA terminus, the middle cerebral artery M1 and M2. However, it failed to mention the basilar artery, which is also included, but this is not because the ChatGPT is inappropriate. It is because there is still a confusion what we should count large vessel occlusion. Today we count basilar artery, which is this one here, supplying the posterior fossa, as large vessel occlusion. This is a basic case of large vessel occlusion. A patient comes in with a big right cerebral hemisphere deficit. These color images are very good for lay people who are not radiologists because they show in basically traffic light coding the severity of the ischemic territory in the brain. This is a right hemispheric. Of course, it is a right MCA M1 occlusion, which is today 1A classification in the guidance. So we are supposed to treat it mechanically. We actually don't need CT perfusion scan for this because CT angiogram shows the occlusion. Some of the sites do not have CT perfusion available. And that is confirmed by the catheter angiogram, and then you can see it very well, but there is a device in there with some markers, and eventually the case is solved. We call this sticky tree, which is complete reopening of the target brain artery, and the patient does a good recovery. Now, today for the large vessel occlusions, all the devices we used are FDA approved. There is a little difference between stent retrievers, which are 1A recommendation, and aspiration, which is 1BR recommendation, but basically there is no difference in practice. Now, let's go a little farther. I asked ChatGPT, what is medium vessel occlusion? So the answer was good. The medium vessel occlusion is occlusion of the M2, M3 middle cerebral artery branches, which are, these farther up. Posterior cerebral artery branches, which are these, supplying the occipital lobe. These account for 25–40% of all acute ischemic stroke cases. This is important because if we don't treat these, then we miss 25–40% of the treatable stroke cases. So we treat them. For example, in actually 2013, this was even before the very special year of 2015 when it became into the general guidance that thrombectomy is actually useful. So at this point, at this year, in this year, no one recommended to treat these strokes with catheters, yet that we had this patient with aphasia. And it turns out that the aphasia is caused by not blockage of a large brain vessel, but only that brain vessel that goes to the Broca and the Wernicke area of the brain. So the patient is aphasic. He can move everything. The sensation is good. He cannot talk. He cannot understand what you are telling him. The patient cannot communicate. It's no good. And it's not a large vessel occlusion. Should we treat this patient? Yes. Do we have, in 2013, the instrumentation to treat this patient? No. So what do we do? Well, we take whatever we have, and this is of course, back then it was off-label use of certain things like intraarterial thrombolysis, TPA, selectively injected, and then I pulled a little balloon that I regularly use for treatment of intracranial vasospasm in subarachnoid hemorrhage cases. And I treated this occlusion with the balloon successfully, and the patient did a good recovery. You can see how this blood vessel opened up. Not everything opened up, but enough so that the patient eventually suffered only this smaller deficit, and next day he had no speech deficit at 24 hours. He did have some fine motor coordination on the right hand, but speech is more important. We are humans. Okay, so what do we do with these medium vessel occlusions in 2023? Well, we do have now equipment that is FDA approved. Currently, the guidelines show a 2B BR recommendation. And this is how to do it. This is a left posterior cerebral artery occlusion. Here it is on angiogram. This is a P2 segment. This is medium vessel occlusion. There is the catheter tip, you can see there, when aspirating the blood clot. And after aspiration, which takes about 5 to 10 seconds, the artery is open. 5 to 10 seconds is the duration of the aspiration. To go there, it's about 15 minutes, average. And the result, normal. And of course, the patient's vision is restored. This is, again, a speech center infarct, or to be infarcted unless we remove the blood clot. But of course, we go there, and here is the tip of the aspiration catheter, which removes the occlusion, and the patient is cured. Here is an anterior cerebral artery. This is, this causes this long-shaped perfusion deficit, left-sided, right next to the midline. The result is, if there are neurologists here, of course, it's right-sided leg weakness. And then when it's treated, before treatment, you can't even see the anterior cerebral artery, and after treatment, the whole thing is open. And this is the resulting chronic remaining injury, which means that the patient walks again. So what does ChatGPT tell about the distal medium vessel occlusions. This is again the next step. We launched the spacecraft, and the spacecraft is now reaching, the outer areas of the solar system. It's near the Pluto. ChatGPT says that these are ACA, PCA, MCA, and that's wrong because it's much more. It's basically, if we tell about the MCA, middle cerebral artery, it's the M3, M4 branches, and the M4 branches are on the cortex. They are between the brain and the bone. The ACA system, it's over the corpus callosum. This is A3, A4. And on the PCA, the very small branches behind the brainstem. So that's what we need to reach. Can we do that? Yes, we can. With today's devices and technology, we can reach there. So we can get to PCA, right? This is right PCA patient has left visual field, full visual field deficit. And if we find that very distal occlusion, this is not a P2, this is a P3 or even maybe a P4. We reach it with a catheter and we reopen it, then the patient will not have a full, as I mentioned, left visual field deficit, only a partial left visual field deficit, which is much better. Or, for example, a very high positioned lesion occlusion with an embolus of the corpus callosum, which can be, as you see, reopened. Or an M3 branch. This is again speech. Speech in humans is very important. When a small branch is occluding a small artery, but it's in the speech area, that's a disaster for a human being. So yes, we can today treat this too. Interestingly, and I would call into your attention that on a CTA or MRA, it's not possible to find these occlusions. It can be found clinically because the patient is aphasic, or it can be found on either a CT perfusion scan or MR perfusion scan. And today, this is why CT perfusion is so important, because these lesions cannot be found on the CTA or MRA. Of course, on an angiogram, yes, but pretty difficult there too. And this is where I should stop and say thank you very much. Not yet. This is the importance of the smaller vessel occlusions. If we consider how much patients we can treat with large vessel and medium vessel occlusions, and how much are the distal medium vessel occlusions, these are basically small vessels, you can see it's a large piece of the pie, it's 1/3. So if we don't treat them, then we lose these patients without treatment, they will get a stroke. Are we successful and safe? Yes. It is not more difficult, at least according to these slides, and these are our hospital's collection for the past 12 months. It is not more difficult, and technically we have the same success with distal medium vessel occlusion embolus removal than with large vessel occlusion embolus removal. However, there is one more thing. So now we reach Pluto. This is, by the way, the New Horizons spacecraft of NASA, which was launched in 2006. And it reached Pluto in 2015. And it still has fuel to run for another 10, 15 years. So what should we do now? So what would you do if one morning you got a sample catheter which can go farther beyond those things that you could reach before? And that same evening, a physician, a retired physician who is like 80 years old of your own hospital comes in with a stroke and unable to talk and understand, totally confused, unable to talk. Of course, you would try that new catheter you just got in the morning. So that's what I did. And if you look at carefully, it's very difficult to see which branch is occluded. It's somewhere here. It's the left side of the brain. But if you follow the video on the right side, it shows that this little marker is moving on a previously uncharted territory. It aspirates the blood clot, brings it out, and I've been on the surface of the brain. This is pretty much undone before, prior to this new technology. And then I reopened this branch, which was the one running to the speech center of the patient. And nothing else is occluded, nothing else, only the speech area. So this was the prediction of the CT perfusion, what happens if we don't remove this blood clot. And this is the end result. On the CT scan next day, there is no damage. And then I received another device, and another patient came. Now the patient had an M3, which is this, and an A4, which is that occlusion. So of course I went and treated that too. So today we have the technology, today we have the skills to go after these small blood clots, occlusive blood clots. And it's interesting to see, I was collecting pictures, and this was published in 2022, just 1 year ago. And this, what you see there, is not FDA approved approach, because we shouldn't use that microcatheter that's not approved for aspiration thrombectomy. But we have 35 thousandths of an inch diameter aspiration catheter today, so we can go ahead and do the procedure with FDA approved devices. So pre-2000, barrier was the technology. We didn't have appropriate devices. Then the technology arrived, and after 2020, now we pretty much have the appropriate technology. Of course, it can be improved. We have FDA approved devices. Guidelines are still lagging. The international and national guidelines still don't say anything about these very distal vessel occlusions. However, the physicians are pushing the boundaries. There is an imaging barrier, I already mentioned that. These small vessel occlusions cannot be detected very easily. It's actually very hard on CT angiograms, so CT perfusion is pretty much a must. And thank you for your attention. I also would call into your attention that this is a teamwork. To perform all these in every single patient within 60 minutes, it's a very strong teamwork. So kudos for the team too. Thank you very much.
Thank you very much for this futuristic presentation.